Great. Hi, everyone. Welcome back to Healthcare. We are switching gears for a little bit this afternoon, and we're going back to H 766, which is our bill dealing with provider burden. And when Sandy Hoffman was with us last week, I think it was last week, I think just yesterday, last week, she had mentioned, she's with DVHA, and had mentioned that DVHA is no longer requiring prior authorizations except for a category of prior auths, and I think pharmacy. So we kind of touched on that, but I wanted to have Sandy come back and go in more depth on how DVHA made that decision, what impact they've seen, so that we have an understanding of one of actually our largest insurance company, probably in the state of Vermont, is Medicaid, how they were able to reduce prior authorizations so that we can think through that when we're looking at 766. So Sandy, I'm going to turn it over to you to introduce yourself and then start your testimony.
Okay. Hi, my name is Sandy Hoffman. I'm the Deputy Commissioner for the Department of Vermont Health Access. As a result of legislation, the DVHA team embarked on a project with the objective to take a methodical approach to reviewing the codes that require a prior authorization, PA, in order to be able to make data-driven recommendations on where a PA is necessary and where we can remove the PA requirement in compliance with Bill H960 and alignment with our work with the ACO. Now, that was the original objective from the work plan that was developed on the onset of the project. There were two deliverables that were identified: to create a dynamic list of codes requiring prior authorization and a documented process for reviewing the list, and provide findings and recommendations to a group of interested parties identified in the legislation. So the team was originally comprised of members from the DVHA leadership, that was me, clinical, payment reform, and data teams. Other units were consulted as needed. Eventually, it became obvious that we needed input from the Special Investigations Unit, so they joined the team. We set up a meeting frequency of one time every 2 weeks, and we outlined a work plan that had the original 8 areas for review. And those areas were high-tech imaging, pediatric physical therapy, occupational therapy, and speech therapy. And that evolved into including adults, out-of-network services, elective and non-elective, imminent harm codes, including hysterectomies, chiropractic care, durable medical equipment and supplies, high-dollar services, and orthodontics. And as I shared last week, the team was asked to focus on opportunities to remove prior authorization, align requirements for ACO and non-ACO attributed members, and align with other insurers where possible. And in order to do this, we identified claims data that was needed, points where literature review is required, and where we wanted to bring in subject matter experts, either internal or external, to provide information to the team. We also researched what other insurers were doing and outreached them when we didn't understand the rationale. There was an identified lead for each area that presented the information. The group members reviewed and/or researched information outside of the meeting times and came prepared to discuss and make decisions. It was very mission-driven, and the original project wrapped up in August of 21 and culminated into a memo that was submitted in September of that year. The outcome of the original review was waiving of PA requirements for high-tech imaging, aligning the number of PT, OT, ST services with other insurers, which was 30 visits without a PA, and that action reinstated PA requirements for ACO attributed members for therapies when it wasn't required before, but raised the minimum number of visits without PA for members that were not attributed to the ACO. So aligned the ACO and non-ACO attributed members. Putting the PA on was largely based on a much higher number of visits for ACO attributed members not needing PA. So they weren't required to get PA, and they used way more services, and it was not in alignment with the clinical guidelines we reviewed. And it also was without evidence of better outcomes than the members that did not have that high level of utilization. The out-of-network services review yielded a list of hospitals that would no longer be required to seek PA prior to treatment, mainly to support access for our members. These are hospitals by our members.
No.
Sandy, you're going a little bit in and out. So can you start with out of network again?
Sure. The out of network, is that good? Out-of-network. Okay. The out-of-network services review yielded a list of hospitals that would no longer be required to seek PA prior to treatment, mainly to support access for our members. The hospitals are close and frequently used by our members. The hysterectomy PA requirement was lifted and a standard operating procedure for imminent harm review was established. Is it still good?
Yes. Yeah.
Yes.
Okay. Chiropractic care visits were aligned with other insurers. DME PA requirements were lifted, provided they didn't fall on the imminent harm code list. And there was a recent review of limits in the system that is likely going to result in a reduction in claim suspension due to those limits. A new high dollar review process was established with an increase in the dollar amount requiring review or PA, and orthodontic prior authorization was also waived. The team continues to meet. Recently, we identified codes that still require PA for non-attributed members, and we're planning to review them this quarter. Some of these are genetic testing, sleep studies, and a 5-time per provider per condition per month PA requirement for non-attributed members. And again, as I said last week, that team is also responsible for monitoring ongoing utilization and reporting anomalies that don't have explanations to senior leadership, the Special Investigations Unit, and the CURB, the Clinical Utilization Review Board. So I think that covers it. We had a meeting this morning, so it's very fresh.
Okay, good. So that was a ton of information. I'm hoping you can send us your written testimony. That's very helpful. So a lot of these were eliminated, it sounded like in 2022.
2020, 21 is when those changes all came to be.
All came to be. So you've had a couple years with it. And I think, correct me if I'm wrong, in your testimony last week, you indicated utilization did not increase.
Correct. We continue to monitor, and when we see anomalies, we have the Special Investigations Unit look into it to see if there's any explanation for it. And so far, there has been an explanation for it. We have such a low number of members, like it's very small population. So sometimes just 1 or 2 members may cause a spike. So we look into it and make sure that that requires a reconsideration of whether there needs to be prior authorization reinstated.
So how many members do you have that would fall under this?
Well, there's over 200,000. And probably about 80% are attributed to the ACO. So the other 20%, although there's alignment now, so.
And now there's alignment. Okay. Alyssa?
To the point of attributed and non-attributed with the ACO, can you just talk a little bit more in depth on when there was prior auth requirements for non-attributed versus the attributed lives were not required? Were you seeing differences in utilization between the two groups?
So a good example of that, and you'll see when you receive the written testimony, is the physical therapy, speech therapy, occupational therapy. So with each of these reviews, we looked at utilization trends for people who were attributed to the ACO and not attributed, and looked to see if there was a significant difference between the two, and then tried to find a rationale for it. So we saw a huge increase in PT, OT, and ST services for those that are attributed to the ACO without necessarily seeing a decrease in other areas. So we do say, okay, there may be times when if there's more of those services provided, the member may be better off, and we might see a reduction in something else, but they may be better off. And sometimes it's better to have more physical therapy than go to surgery or something like that. But we didn't see a reduction in those other areas as a result of the increase. So we said, you know what, maybe for those services, it would make sense to align with other insurers and then put PA on for attributed members, but raise the limit. So it was 8 was the limit. We raised it to 30 and aligned the ACO and non-ACO. Because we used the data, and the data indicated that we probably should look at it. And we'll review it again. But at that point, that's what made sense to the team.
Thank you.
Okay. We're also,
Go ahead.
We're also looking at a way to, right now, my understanding is there might be a challenge with determining if something needs a PA. So we're looking at a way to improve our system. I sent you the link last week for how providers could see if something requires a PA. And I think we're looking at adding a column for if there's the ACO delineation, but really we hope to align it across the board. That's the goal.
And so when you do make a change to a prior authorization, what is the how does it get notified? I know you have the website, but like, what's the timeline? What's the process?
Something came up today that the last thing I talked about, I think, was the 5 visits per provider per month per condition. And that requires a prior authorization for non-attributed members. We haven't seen requests for authorizations for that. So we say, okay, we should lift that PA. We don't receive those requests. And if we do receive it, it's going to be authorized. We've had no exception requests. Like, we look at all of those data points. So then we say, okay, there's a change to the state plan. There has to be a change to the state plan because it's in the state plan. So then that means we have to provide notice. So on we have to post it for comment where we're lessening restrictions. So it takes a little longer than we like it to, but we have to adhere to those requirements too. And we might do banners. It depends on what the service is, if it's something that's used. And we've been doing a lot of work with the ACO providers over the last couple years because we still get PA requests for things that don't require prior authorization. So we've been working with them to teach them that they don't need to submit those and that those are aligned, the ACO and non-ACO. And that's why it's glaring to us that we need to improve the system so that they can look right online and see whether or not.
Well, and we did hear from providers that sometimes they just submit a prior authorization just because it's too hard to take the time to figure out whether or not they have to. So, Alyssa?
That was sort of my question. If you had data around prior authorizations that were submitted on attributed lives that ultimately weren't needed.
Yeah, I can get that for you. We do track.
And can I just say that giving providers a way to see that somebody is attributed would be really spectacular.
Because they don't maybe know.
Because you just don't know.
The more access to a list of who's attributed and who's not. Okay.
Yeah. As opposed to just, the ACO's spreadsheet.
Okay.
Sandy, I have a question. So I'm wondering, before this data-driven group got together and made these recommendations, these changes were made. So the before and the after. Has there been any change in staff? Like, were there more staff dealing with these things before your change? And is there less staff now? Can you give us any idea if there's been an impact?
I don't know that it's necessarily related to that. We did a lot of work to ensure that all of the staff that we had were being used appropriately and that we were staffed at the right level.
Okay.
If there's a reduction in prior authorization requests now, that those staff, they're all clinicians who do the utilization review. They're now available to do other things.
Got it. So you have seen, so
savings.
no reduction in staff per se savings, but there's kind of a shift potentially in the time that you do for prior auths versus something else.
Yes.
So, okay, great. Leslie,
Something more meaningful. What they're
Yes.
doing is more meaningful.
thank you for that last statement. That's perfect.
Yeah, that's really important. I'm just trying to understand the context and all the numbers you gave me. I'm sorry, I didn't take in, so I'm looking forward to seeing your written stuff. But I'm curious to know what % of claims are we talking about that require PAs? And then how many did you get rid of out of that? Does that make sense? Because I just want to understand the context of what we're talking about.
I'm trying to figure out. Give me the question one more time. Like, what is the percent, the reduction?
Yeah,
I
like
just-
you get X number of claims and I don't know, months, whatever makes sense to you. And then how many required a PA for originally before you did this work? And then how many PAs are left? And what percent of your claims require PAs?
Liz, are you just trying to get to the number it was reduced by?
Yeah, I'm trying to understand the impact of the work that you've done and how much more impact can we have in the PA role. I mean, I understand the impact of the clinician's office clearly,
Right.
but I'm trying to understand how it crosses over.
One other thing that I failed to mention before is that the physician administrated drugs also are in alignment for ACO and non-ACO attributed members too. So that's a big chunk of work too. And that may have been an addition of prior authorization for those members that were attributed to the ACO, because it allows us to negotiate those rebates, those supplemental rebates that I told you about. So without the prior authorization, we're not able to do that. So we did align those, but it's adding PA to the ACO attributed members, much like the PTO, TNST. So
Okay.
I'll think about how to answer that question. And I think I get to what your intent is. So I'll work with the team to try to figure out some way to provide data for you.
Only if it's sort of useful for you, I mean, or for us, as we think about this. I don't want you to go down any rabbit holes for sure.
Okay, appreciate
but-
that.
Yeah, I'm curious to know if most UPAs is what I'm understanding is about the pharmacy side of things. Is that true? Like, where do they live? Because you talked about OT and PT and hysterectomies. I can't believe hysterectomies are that many. I hope not, that kind of stuff.
Yeah, no, the drugs are kind of separate, so those, I don't want to say that there's more of those than there are for the medical prior authorization. There probably are, but that doesn't, that's a quick system. It doesn't require a lot of clinical documentation to support the prior authorization request. Those clinical authorizations require a little bit more work, a little bit more needs to be submitted. And I would guess that there's probably about 500 a month.
500 a month.
Mm-hmm.
That's the clinical side.
That's the clinical, yeah, the medical, the non
On pharmacy.
drug, yeah.
And how much staff sort of handles that?
A team of maybe 5.
And how many of those get approved, you think?
Oh, I can give you I don't want to say what the rate is, but I can
Yeah.
get you the approval rate.
Okay, well, yeah, thank you. I'm just context. Thank you.
Melissa?
And just really quickly, the services that you do still require prior auth on, are they time limited? Is there, a date range, an effective date, like a 3-month span, 1 month?
Some services currently, so I think I mentioned TMS last week, and there's a very prescriptive time period for when TMS should take place. So that would be a time limited. That would be an example of a time limited one.
I'm just wondering if with some of the wait times and scheduling that we're seeing, if that has been an issue where prior auths have to then be redone?
No, usually we could just do an extension. Could move the end date with just something from the doctor that there was wait or something like that. We wouldn't require the whole process begin again.
Okay, thank you.
Any other questions for Sandy? This was very helpful. Thank you. I appreciate all the work Diva and everyone that was involved in this process did. Again, it would be great to have your written testimony so we can get all the categories right. And I appreciate you coming back and walking us through this. So thank you.
Thanks for having me.
Thank
Take
you
care.
very much. Thanks. All right. So Floor is at 3. Anyone, let's maybe just take a moment. So take a breath. So prior authorizations, we've gone through and we'll be continuing testimony, but we've pretty much gone through the prior authorization piece and we've gone through the claims edits. Blue Cross Blue Shield did respond to our list of questions yesterday. I need to get them out to everyone, so I will do that when we're done here. So we'll come back to that testimony. I'm looking at our schedule. I think, yeah, so tomorrow afternoon, we'll come back and we'll do the last couple sections of the bill, which is about collection of cost sharing amounts. And then we will also talk about claims edits at 1:15. So I will definitely get the answers out to you so you can all review those before Blue Cross Blue Shield comes back in. And then next week, the first part of the bill is about step therapy and pharmaceuticals. So we'll get to that. And then we'll start having some committee conversations about what we want to do with the bill. And go from there, unless there's anyone has any comments they want to make now or thoughts or.
Well, you know what I didn't ask Sandy, I kind of wish I did, is the report sheet they put out, is that on our legislative report list by chance, do you think?
The report,
Did they not put a report out about the PAs they did away with?
is there a,
I
Alex,
don't believe there was a report formalized.
can you just say for the record?
Yeah, I'm sorry, for the record, Alex McCracken, Department of Vermont Health Access. I don't believe there was a formal legislative report on the
Okay.
prior authorization. I'll double check on that for you, but I'm pretty sure that that was never a formal request.
Yeah, well, maybe her testimony.
Our testimony, I think when we get the written testimony,
what
it'll
it-
help.
And
Yeah,
I have just sent that over for.
Okay.
Yeah.
great, thank you. Any other comments, thoughts or questions on 766? Right?
I just appreciate that we're steadily moving forward with it.
Yeah.
And hope that we can be done with it soon and give more attention to the other things.
Yeah.
But I'm happy that, I'm happy so far with the process.
Good, thank you for
Just,
that.
but just like sort of encouragement or whatever.
Thank you.
Yeah.
I appreciate that. I think these are really important topics to our provider network. So I appreciate that we're taking the time to go through it and get to the point where we can start having a conversation about what we want to do.
So that, when you just said that though, it triggered an idea.
Okay.
Because you mentioned provider networks and although like I want to do this for the providers, ultimately, I think that as a provider, I want to do it for patients.
Yes.
It would be good at some point in our process, not necessarily for this bill, but like as part of our process this year with the work that we're doing, to maybe consider a public hearing or something where patients can come out and tell their stories, even though we know those stories. I feel like people need to be heard.
Yeah.
So maybe as part of our talk on Medicaid expansion or just our committee's work, there would be a night where we, and I don't know if we can do that with COVID, post-COVID, but like, or if it could be on Zoom, but it would just to have a space, an hour or two, kind of how we did on other issues over the years. If there was a way to do that, I think it would mean a lot to people to be heard.
So I appreciate that. And we are getting a big push to do a public hearing on the Medicaid expansion.
Okay, yeah.
I'm meeting with someone tomorrow. I think what I would like to do is have some Vermonters come in here and explain how this would impact them, how, being in the income levels they're in and not being able to get Medicaid has impacted them. And then we'll encourage people to send written testimony. But I need to.
So at the least we're doing that.
At least we will do
Okay.
that.
Because that was powerful in the beginning when Mike Fisher and his team presented and we got to
Yes.
hear those StoryCorps kind of things. But I think it's even more impactful if we have the actual individual. But it put such a fine point on it and brought it right to the.
And the other thing I've asked for, and I think we might have gotten it, but I'm not sure. The healthcare advocate was going to put together a sheet that showed the income levels we're talking about. So I don't know, no, not that. So more of a, when we talk about MSP, more of a, okay, this is the income level of someone at 100% of the FPL. This is what they're paying when they go to Medicare.
Yep.
And this is what it would be if we pass the MSP part of this. So just to see the raw numbers. So if he hasn't sent that in, we'll make sure we get it.
Yeah, this bill, 766. And in all the testimony and all the words said about all these things, I might have missed it, but is there going to be cost savings with this? Cost to the customer, cost to the person getting the service eventually.
So,
And I think this is important because if we're going to do it, there's got to be a reason for it. And one of the reasons beyond timeliness of care should be cost. I mean, if we're eliminating the need to go through all this administrative baloney, then maybe we can get, I hate to say rid of, but drop some of these folks from the payrolls if we don't need them because of it.
right, so I think, I received a research paper. I have not read it yet, but so I will read it to you. There have been a lot of studies that have been conducted on this process, and I don't want to quote anything. It's very hard to ascertain the cost outside of the cost to the insurance company. So, Blue Cross came in and said, and I'm not picking on Blue Cross Blue Shield, but they were the ones that testified. They said they saved $30 million by having these prior authorizations. And we heard from providers who've had to hire staff to handle it.
Mhm.
Patients have access to care issues.
Right.
Providers, we got a letter today where I think a provider said I could see 4 more patients if I wasn't spending 2 hours a day on prior auth. So those are the costs that we're talking about that will help people, will help providers, will help patients. It's just hard to quantify that.
Yeah. I get that, but the more, if we can, not that it really matters for this bill, but, one of our aims needed to be.
Yeah. Well, we would be, so, the question we asked to Diva, they have people who now have more time to do what she calls meaningful work.
Yep.
That are not being spent on prior auth.
Yeah.
So I would suspect that would be
Trickle down to,
throughout the healthcare system.
okay.
But I agree, Art, if we get any of those numbers, it's so powerful when you tell the story to the public and you're trying to help someone understand, because no one's gonna sit through what we sat through with all the explanation, but if we can just, even if it's a couple of data points, that would.
Yeah, even if it's something.
One data point, UVM,
Yeah.
Mental Health Network has 77 people doing prior authorizations.
Right now.
77.
Thank you for that. Yeah.
Right.
So since this is a chance for committee discussion, I want to respond to that about cost versus benefit analysis here. So just immediately when you said that, Art, I was thinking about cost benefit to everyone. And what I see, and we can try to get more data on this or more testimony to back it, but I'm not making it up. Like I can even find some sources to back what I'm going to say. But we would see reduced cost to the customer, the client, which reduces a barrier, which means then they have increased access, which then increases prevention. And the higher level interventions cost the person and the system more. So by making it easier for a person to go to their primary health provider or a specialist earlier, it's saving money to them, at the very least to them, later for those 20% hospital copays, et cetera. But then think about all the people who aren't able to pay their bills, that then saves the hospital money. And then if we zoom out even further, like that health, the social determinants of health, 50% are health related. The last I looked, 16% is directly impacted by healthcare access. So that means that by increasing access to healthcare itself, we are improving 16% of the influence on the social determinants of health, which affect like the long-term trajectory of public health and the cost in the long term on society. The other 34% are health behaviors, but the increased access to this care would influence health behaviors, because if someone is going to the doctor more, not maybe more often, but more regularly, and instead of having staff doing billing if they were hiring staff to do nutritional counseling, like we heard people saying, and all these other things that help change a person's behavior, we could have an impact on 50% of the impact of social determinants of health through this decision. And so what I'm getting at is that in the long term, the savings on society could be really massive. So it's not just the individual, like we're saving that person, but it actually amplifies. I guess, and so we can hear more testimony on this.
I get it.
Yeah. That's what makes me excited is that it's a generational thing. Like it's going to help
Right, it's not
now.
gonna be overnight.
Yeah.
Right, yeah.
Yeah.
Leslie?
It's a really important point when we think about community benefit, because we spend a lot of time on dollars and cents, but we don't really think about sometimes how it really benefits the community beyond the finance. And I think we need to think about that more deeply, because it'll be better for a lot of people when we think that way. Community benefit's a big deal.
Thanks, Leslie. Les?
I just don't want to lose sight of, if we're talking about the cost. And I know because I witnessed this. I mean, I worked in a practice for 26 years. Provider burnout is real. And it is profound. I mean, the people that I started working for 26 years ago have burned out and flamed out because they could not take it anymore. And it wasn't seeing patients. I've never, ever heard a provider, ever, even the providers I don't care for. I've never heard a provider complain about caring for their patients, ever. But I have seen people just, again, flame out because they cannot handle the administrative burden that is put on providers. And it's not just prior authorizations. It's a million other little things of checking boxes.
EMR.
And, quality measures and, these people just want,
Not being able to spend the time.
Yes. You need
could,
to spend.
want to.
And want to spend.
Yes.
Okay.
That's what I'm talking about, community benefit. It's hidden and we don't see it. But these kinds of changes does affect community.
Yeah, good.
It amplifies.
Yeah.
And on the flip side, the insurance companies will say that there is a potential for premiums to premiums to increase because we've eliminated these.
Yeah.
So that is the flip side to the conversation.
Yeah.
We don't know that, but that is the flip side.
So I'm not a witness right now, but this is committee discussion. I think our lived experience is important as patients and providers, et cetera, that we decoupled, maybe is the word, divorced, separated the individual and group market in the exchange.
Yes.
My insurance is at a point that I almost dropped it. I'm paying $728 a month. That's the cheapest plan I get. And I do get a subsidy at the end of the year. Like I get like a tax break because of what you heard earlier about the federal policy. That's set to expire. If that expires, I will drop my insurance. Like there's no way. So it's critical. And I'm a healthcare, what's sad and the moral injury that we hear about, like as a healthcare provider to not be able to get what you give others, it's very insulting and hurtful to continue to live with that. And I'm feeling increasingly resentful. So that being said, I am nervous personally about supporting this because what is it going to mean for me as an individual on the exchange? But I'm willing to do it and drop my insurance if I have to. But that's, I think, what they're talking about, because then you're pulling people out and then people like me can't afford it and we drop out and then the prices skyrocket.
Yeah.
So that's why I think we need a public option, because then we can all just buy the public option and see what happens.
Yeah,
That's in my own self-interest to buy for Medicaid. Medicaid would be I'd rather pay $728 a month for Medicaid than what I get now. So,
Well, yeah, Medicaid's the best.
On that note,
yeah.
if there's nothing else, I'll say we're done
All right.
for the day and we'll see you tomorrow.